I think we'll just go through. This is what the nuclear medicine study. So it shows showing increased uptake in the sacroiliac joint, and so CT shows some changes, sclerosis, and the fused images show uptake in both sacroiliac joint. Again, you see in the planar images some increased uptake in the left hip joint. And then look at the CT. You see some degenerative changes which corresponds to the uptake here, and again is degenerative changes in keeping with the narrowing, subchondral sclerosis, and set formation there. So it's just you need to add, look at the other side and look at this side, and look at the uptake corresponds to the sclerosis, which is probably normal joint. So you can see that the early changes when you see on degenerative hip will be around here, osteophytosis along the superior lip of the acetabulum and the femoral head. These are the very early. So on a plain film, when I'm reporting, I say early changes seen in the hip when I see some osteophytosis here. But when you see destruction like here with subchondral cyst, then this is advanced, and that corresponds to uptake here. So you see uptake, and we've already discussed, so you need to know exactly where the uptake is. So looking at this, very symmetrical, predominantly more advanced on the left side, sits nicely. That's probably the tendons coming in here, and that's the space in between the bone and the tendons. Corresponds nicely. This is more marked, and here nicely, and you can see the muscles coming in, and that's the area. So is bursitis. Again, looking at it now, look at this. So what is it? Sorry? Spontaneous. Spunk. Yes, could be depression, and but bilateral could be, depends on the history of what the patient had. Not spect, but then you go back to the history. Spunks you normally see in patients who are diabetic. Yeah, so I think so it could be fracture, it could be degenerative involving the medial medial compartment of the joint, and it looks like on the planar it's involving the femoral part of the joint. This spunk is suppression and depression of the medial tibia. Yeah, this one. Yeah, that's what I'm seeing. So basically, this to me on a planar looks like more predominantly on the femoral side, and spunk you will see is depression fracture with the medial side on the tibia. Yeah. So it's very symmetrical, and then history will guide you. The other thing, that's why we keep stressing, and the clinicians don't understand, that they need to give us history. If this patient, if I had only unilateral, and still on the planar I would have said these are femoral, probably degenerative, no mark. But if you've got on the tibial side and uptake, you can see it sometimes in the unicompartmental arthritis involving the medial plateau. But then if you have got diabetes and female and overweight, then the diagnosis changes. Then that's a fracture until proven otherwise. So we discussed about the symphysis, increase uptake. So you see some irregularities, sclerosis, increase uptake bilateral. There's some changes in the cortex there. So again, look at the outline here. The posterior and the lateral parts are very pristine. As you go along the anterior part, you see irregularity. This one is still relatively better. And then you've got loss of joint space. So osteitis pubis. Yes, yes, it's but yes, that's the common. I think when I started my training, we used to do squat views. We do, but now because of the time constraints and all that, and we've got spect and all, so we, yes, but yes, it's commonly seen. So, and sometimes if you've got bladder activity, it's and even I am probably a people. If you don't do the squat view, if you don't do a delay, you miss solitary mets in the pubis and inferior pubic radius. It's quite often, and it's very dangerous. Yes, exactly. And proper views. So radiology and imaging is proper views. So whether you empty the bladder, you do squat views or do something else, don't just let the patient go. Have you done the knees? Okay. You've done it. Okay. So we have talked about this. So sclerosis, and so this is very marked, and this localizes to the uptake there. It's not quite evident, but you can just see barely a lucency there. You can see it here, and then you can't see because it's fused. There's just sclerosis there. So, and it localizes with the uptake, and this is probably a defect, is it? Osteochondral defect. Yeah. So the thing is, you need to make sure. I think what I remember, the metastasis is always like if you see lung where the vascularity is, so it normally follows the blood and it goes and metastasizes. So wherever the bone circulation is and the blood flow is, normally that's the dominant side of metastasis. No, the osteochondral different benign lesion. So patient has CA breast. Question was metastatic lesion in the femur. So this is well in the position. This is tracking along the lateral condyle and causing uptake. So it's degenerative. Patellofemoral degenerative disease again. So here it nicely shows you. So that's the cartilage of the patella. That's the irregularity. That's the cyst formation and sclerosis. And now what I was saying is basically you've got this two surfaces, lateral and medial. So it's basically rubbing onto the surface, causing reduction in the joint space, and is degenerative. This is causing the pain. Pain with knee, patient with knee pain, more on the right side, post-renal transplant, question mark AVN. Yeah. Sometimes it becomes difficult, but I think again, history is very important. So left knee pain, bipartite patella. So again, you see uptake, increased blood flow activity, delayed images show some patchy changes there. So it's a lateral part with increased uptake. So athlete with medial right knee pain, tender on femoral condyle, quadricep tendinosis, just subtle increase. Then you've got increase on the delayed images. So if you look now here, you see what I was saying on the CT. This is the fat coming in, and then you lose that. So there's something going on. This is thickened, and then this shows uptake. So there's some inflammation going on, and this is a quadricep tendon coming through and attached here. So there's inflammation. So that's tendinosis.